Thanks for rejoining us. I hope you all enjoyed the break. We are going to move forward now. We're very pleased to have Dr. Ann Albright. She leads the prevention team at the Centers for Disease Control and Prevention. Technically, she is the director of the Division of Diabetes Translation for the CDC. She previously was the chief of the California Diabetes Prevention Program in their Department of Health. She's held a variety of other positions in this specific topic. She is widely published on exercise, nutrition, public health practice in diabetes prevention, and she's going to talk to us now. She's going to expound a little bit on what we heard last time in terms of who is affected, how bad is it. So we'll talk about the scope of the diabetes epidemic and how it affects us. So, Dr. Albright?
There we go. It works. Okay. So that's to go forward, that's to go back, and this is laser pointer.
Perfect. Thank you. Hi, everybody. Certainly you heard quite a bit from Sue this morning, Dr. Kirkman, and lots of great questions you all had. I hope we can absolutely continue that dialogue. I am going to be presenting data and information to you, and I think sometimes people are happy to get the numbers, but they glaze over a little bit, so let's make this really meaningful and useful to you. My background is as an exercise physiologist and registered dietitian, and I've worked both in clinical care and basic research, and now in public health and public policy. I also live with type 1 diabetes, and I have for almost 44 years. So I wear a bunch of hats. Not that I have all the answers to all of your questions, but I hope we can really use that to round out your interests and your thoughts and be sure that this is really well spent time for you and meaningful for you. Let's begin. This is actually, I'd like to start out a presentation on the latest statistics and data from CDC with this image, because I am going to be talking a lot about numbers, but no worries. People are behind those numbers. Your family, your friends, your neighbors, people in your lives, people in my life, people who we care a great deal about. So the numbers are important, however. That middle image is we've got to be able to have population data. If we're going to be able to monitor a problem, determine how well we're doing, where the issues are, whether they're in subpopulations, whether they're in geographic locations, we do have to think about the population in addition to the individuals who make up that population. So at CDC and the awesome team that I get to work with in the diabetes division, we really are incredibly committed to the people who stand behind these numbers. A little bit about the surveillance system at CDC. We get a lot of questions about this. I think sometimes people think we sort of line people up and count their heads, and I wish it were that easy. It's not. Diabetes is not a reportable disease, and it's not to say that even if it were a reportable disease that it would make it easier for us to do some of the things that we're trying to do. There are reportable diseases, cancer being one of them, but diabetes is not a reportable disease, so we have to rely upon these sorts of data tools. And this picture gives you a sense of the kinds of tools that we look at. You may have heard things like telephone surveys. This would be the Behavioral Risk Factor Surveillance System, the BRFSS. We use NHANES, NHIS, a lot of those surveys. They have a tremendous number of strengths. They also have some limitations and weaknesses to them, and don't let us always get at some things that we would like to do. We also use hospital discharge data, we use household surveys, we have used vital statistics and other registries. So just wanted to give you a bit of a flavor for sort of where these come from. These also may not be the sexiest tools that people think about when they're talking to members of Congress, but without the support that we get from Congress, we would not be able to manage these surveillance tools. And so the data I'm going to give you on kids is a special kind of study, and I want to be able to share a little bit more with you about what's been involved in that. We have the only study really like it of its kind going on in the world related to diabetes in youth. So all of this you're going to be able to find, much of the data that I'll talk about, you'll be able to find in the National Diabetes Fact Sheet. This has been an effort that CDC has done by inviting partners to join with us, because certainly you who are members of the media and the press may get somewhat frustrated by the fact that you hear a variety of numbers when they quote how many people have diabetes, how many are undiagnosed. This really serves as the national surveillance system. CDC is charged to run the nation's surveillance system. And so while we don't say, okay, organization X, don't put out diabetes data, we certainly try to help people do the best job if they're going to go ahead and do it. But we really are trying to encourage people, you don't need to do it. This is being done already, or much of it is being done already. So we invite partners to work with us. So the American Diabetes Association, Juvenile Diabetes Foundation, a Diabetes Educators Association, a number of organizations are invited, NIH, a number of other federal agencies are joined, they join with us to publish this national fact sheet, and it does serve as the sort of go-to piece of information. There may be data on there that you need to know more about, or there are things that are not on there that you'd like to know about, and of course we would be happy to try to answer those if we can. So just really want to encourage you, go to the CDC/diabetes website, and we'll give you another contact number to call if you have any questions. Okay, you've heard some of these numbers before. We're so thrilled when people cite the data that comes from CDC. It's what we're there for. One of the things we're there for. And surveillance, which is what I'm going to talk about, is only one of the jobs that we have in diabetes at the CDC. There are 26 million, 25.8, it's almost 26 million people with diabetes and the 79 million with prediabetes. I like this image. Does anybody think of the Titanic when you look at this picture? We hope you do, because there is a lot brewing under the surface here. There is a significant number of people who live with this disease. Again, as you heard, about a quarter of them have it and don't know they have it. But that's 79 million people under the surface is a huge number of people that we have the opportunity also to do something about. And so a few comments today, and certainly on the panel this afternoon, we'll talk a bit more about what we're doing at CDC to build the National Diabetes Prevention Program, which is an exciting opportunity that's going on right now. So these are kind of the hallmark numbers around, and we call this prevalence. This is prevalence, and that, again, is the total number of people at a given point in time who have this condition. The other term you'll hear a lot is incidence, and people interchange those all the time. Incidence is the new cases of diabetes. So within a year, those new cases that have been developed. So prevalence would be the total number. Incidence are the new cases that come in. So here's some more information on those latest data, again, all off the fact sheet. Sue used some of these in her presentation, so you can see, again, the diagnosed and the undiagnosed. The percentage of those over 20 who have the disease, 11.3, and as Sue quoted from our fact sheet, the 26.9 who are over 65, and again, those people with prediabetes. So those, again, are your go-to numbers. Another way to present this to you, what portion of the population have diabetes and prediabetes. It's not that all the people with diabetes reside on the East Coast by any stretch, and all the people with prediabetes reside on the West Coast, but this was sort of a patriotic way. You're going to see some more CDC maps. We've come to get a bit of a reputation for those maps, and so here's a different kind of map. This just gives you a flavor of what we're talking about size-wise between those that have diabetes and that enormous segment of the population that has prediabetes. And here are those maps. This does give you, again, those obesity maps or diabetes maps across the top and the obesity maps across the bottom. These are a nice way to tell a story in a very short period of time to demonstrate what has happened to the prevalence. And the question earlier about the relationship between obesity and type 2 diabetes, there certainly is a very strong link between those two disorders. When we look at these data differently, when we map them out over time, there is an inflection in obesity that precedes the inflection in the increase in diabetes by about 6 years. And that inflection does take place in the 90s. And so a lot of people have said, well, what happened in the 90s? Well, there certainly can be some things that are attributed to being able to collect better data, more complete data during those times. You always have to consider that. But there are also truly more cases developing. And I actually challenge our maps a little bit when I put these up here, because it's important to note that we're talking about prevalence in these maps. Again, right, total number of people who've developed diabetes, who have diabetes. There are some good reasons why the prevalence is going up. I know that might seem counterintuitive to say that, but the more people who get diagnosed, the prevalence will go up. The earlier we diagnose people and get them into treatment, the prevalence will go up. Now, the bad news is the more people who absolutely develop the disease, That's obviously not a good reason, and of course that will cause the prevalence to go up. So you can't always think about the maps getting darker over time as only being bad news. Obviously, the majority of it is not something we're happy about, but finding people and getting them into treatment sooner and also as people are not dying from diabetes prematurely. You know, you go in and out of the pool. If you come into the pool, we don't want you to die prematurely. That's also going to make the prevalence go up. And the death rate overall in the country has gone down, and the death rate due to diabetes has also gone down. All of those things are going to make the prevalence go up. So maybe to think about these maps just a little bit differently than you have in the past should still really, though, reinforce for you, gosh, we have a lot of people with diabetes. We have a lot more people who've been developing diabetes, and we really need to be taking consistent and effective action on their behalf. I'm going to show you a couple sets of maps that are new, and my division actually has led the way in doing these. These are county-level estimates, and it is the most commonly asked for piece of data that we are asked to provide because people want to know in their communities, what does it look like in my area? And these are not easy to do. They require a very sophisticated Bayesian modeling mathematical technique in order to do these. We've done them on, as I will show you, diabetes prevalence. We've done them on obesity, and we've done them on physical inactivity in concert with our sister division. When they come up for you, you're going to notice the images getting darker over time because they are giving you information from 2004 to 2008. So here are county-level estimates for diabetes, and you can see over time what's happening at the county level as they get darker and darker and the prevalence goes up. So this gives you a sense of being able to look at these data at a smaller unit than a statewide. You can actually get in and look at specific numbers within really county-level areas. So if you're particularly interested in what's happening in a more local county jurisdiction, you can take a look at that as well. And the next one is going to be for obesity. So you can see the same kind of imaging as over time between 2004 and 2008, what's happened to the prevalence of obesity at the county level. And finally, physical inactivity. We have, from this information, developed what is called a diabetes belt. And if I go back to the images on the diabetes, you can see, if you look in that southeast region, that really is considered a diabetes belt. And while it's not necessarily a continuous area, it is definitely indicating that there is a higher prevalence there. And it turns out, it doesn't mean that there's not high prevalence is sort of mattered around the country. It doesn't mean you're safe if you don't live in the southeast. But it does say that even all things being equal, there still is a higher likelihood of having diabetes in that part of the country, which really should cause all of us to be asking questions about the physical environment and the economic environment and what we refer to in public health as those social determinants of health. And I'll speak about those in a moment as well. Again, we really want to put these data in the context of what's going on in these communities and to help community leaders determine the best ways to tackle these problems and identify what's going on. So again, here's a little bit more information specific to that diabetes belt. We just did a congressional briefing on this not too long ago to really be able to point out some of the specifics about that belt, and we can certainly give you more information. We have a publication on this area as well and a bit more discussion around what's going on in these counties in the particular belt region. I could not talk about diabetes data without giving you a sense of the information by race ethnicity. This is incredibly important to us at CDC, is really to be able to do this work well. We'd like to be able to do it even better. It is often challenging to collect data for subsets of the population. We've been doing a better job with some of the Asian subsets in the population, but that can be very difficult data to collect. But wanted again to give you a sense of 7.1% of non-Hispanic whites older than 20. And again, I should really reemphasize the data that I've presented so far are all for adults. None of this is in people under the age of 20, so this is all for adults in the U.S. And then again, looking at what the rate is, 18% higher for Asian Americans and 66% higher for African Americans. So giving you again a sense by race, ethnicity, and we'll give you a little bit different picture of that in just a moment.
Excuse me, that's a little confusing. You say 18%. Sorry.
Yeah, that's fine.
It's confusing when you say 18% higher and 66% higher. Can you give us the actual rates so we can compare it with the 7.1?
Yes, we can give you that. It's 7.1% for non-Hispanic whites, so it's 7.1% versus 18%.
I thought you said the 18% is higher. Is the actual rate 18%?
It is for some sets of the population, for some, and I'll show you that in just a moment. So hang on, I'll show it to you in a graphic format that should make it clearer. Let me just go right to that now since it was, okay. Here gives you the actual rates by ethnicity. So you can see, let me use the pointer, 7.1%. Then for Asian American, 8.4, 11.8 for Hispanic, 12.6 for non-Hispanic Black, and 16.1 for American Indians. So there's the answer to your question. There's how 7.1 compares across all those ethnic groups. I'll leave that up there for a moment. I have one other one to give you a little bit even more detailed description. And on this next slide, you'll still see those bars, but this gives you what subsets we have. So you can see here within the Hispanic population, there are subsets for Cuban and Central South Americans, Mexican Americans, and Puerto Ricans. So it gives you a sense of, even for the, again, Cuban, Central Americans, by taking all three of these bars, this is how we arrive at the 11.8. So you can see bigger contribution in Mexican Americans and Puerto Rican than in necessarily Cubans. And the same over here for American Indians. This is a very diverse population of people, and American Indians and Alaska Natives. So this gives you a sense of what contribution Alaska Natives makes and what American Indians, in particularly the southeastern part of the country, or sorry, the southwestern part of the country. And together these make up this overall 16.1%. So trying to give you even a little bit more information about the subset populations. Somebody go to the, I guess it's to the mic for everybody.
Yeah, there's something that caught my attention, the non-Hispanic whites. So I am a white Hispanic. So is this an indication that is more cultural and environmental than race?
That's an excellent question. It's a challenging, I think you're going to ask all good challenging questions today. It is a challenging question to answer. There's no question that there are cultural, environmental contributions to eating habits, to food preferences, to the way food is prepared. Those things all make a contribution. There certainly may be some genetic contribution. Those are being investigated. There has been some information about a subset of Hispanic Latino population that has demonstrated a genetic contribution to a higher rate of diabetes, but that certainly hasn't been found for every high-risk racial ethnic group at this point in time. So the best way to look at diabetes is particularly type 2 diabetes. There's an old analogy from the 20s. Elliot Jocelyn said, your lifestyle or your genetics loads the gun, and your genetics loads the gun, and your lifestyle pulls the trigger. And so you really can't separate those two. It's very difficult for us to separate those two contributions. Other question people had? Okay, great. So again, we've given you right now primarily data about the prevalence of diabetes in adults, and done it by giving you some geographic distribution, giving you some racial and ethnic distribution of the prevalence, the total number of people who have diabetes. Now let's take a look at, again, gestational diabetes. Some good questions about that earlier. 2 to 10% of pregnant women will develop gestational diabetes. Women are much more likely, as you all noted earlier, to develop type 2 diabetes postpartum. 5 to 10% will develop immediately after pregnancy, 30 to 60% within 10 years. And these are newer data than what's been quoted before, because there's been a new definition for the diagnosis of gestational diabetes. So that will likely drive some of these numbers higher. If you're around this afternoon and hear a bit more about the National Diabetes Prevention Program, the question asked earlier about what should these women be doing postpartum, we really have them as a target audience for getting them recruited into the National Diabetes Prevention Program, because there is a structured, proven lifestyle program. And because women with a history of GDM are at such high risk, you can think about GDM as a preview. You've now gotten a little visit into the diabetes world that was brought on by the hormones of pregnancy and those changes that occur during pregnancy. And so it's giving you basically a preview of what you may be in for as you age and get older. So it's important for people to realize that is a population for whom preventive efforts postpartum are very important.
Can you talk about the new definition of diabetes? When did the criteria change?
New definition for GDM, for gestational,
okay.
not for diabetes in general, but for
Okay.
gestational. It really has to do with the tests that they're giving and the values for glucose. And it hasn't necessarily been adopted by everybody yet. The ACOG and the other pregnancy groups are still examining whether they want to take that data on as the new diagnostic criteria. Hard to say. These groups sort of operate on their own time frame.
So if it's hormones that kicks the gestational diabetes in at that
In
point,
high-risk women, you already have to have some of the genetic contribution. This is very closely linked to type 2 diabetes.
right. So are the hormones later on in menopause also playing a role in type 2 diabetes?
Not known. It's unknown whether that's really a contribution. It happens in men as well, so certainly couldn't be, but maybe it's a particular factor. It's more likely to be increased weight, whatever it is that causes you to gain that or to put on that excess weight. Hormones can certainly contribute to that.
Dr. Albright, if you want to take questions, as you go, that's fine. If you'd rather ask people to wait till the end, that's up to you.
I leave that to the group. It sometimes makes it a little more interesting to go back and forth, and I know, Linda, you'll hold me to the time. So as long as we stick to our time frame, I'm happy to have you all asking questions as we go along. If I think I've got better answer in a slide up ahead as I did earlier, I'll just ask you to hold on for a second. Okay, let's take a look now at diabetes in youth. This is an area that we are asked quite a bit of questions about, particularly because the picture for diabetes has been changing in our youth, and because we really don't have a national data system that is collecting data in this population. This is people under the age of 20. So the CDC, and we invited our colleagues at NIH to join with us. We are conducting a study, an epidemiologic study called Search for Diabetes in Youth. We call it Search for short. And a number of papers have been published out of this Search study. It is an epidemiologic study where we have chosen some sites around the country who are monitoring the new diagnoses of diabetes in children, monitoring the follow-up of those children. This study has been going on for 10 years now. We're entering into what's called Search 3, the third phase. We do it in 5-year blocks of time. And it really is one of the most complete, largest studies of diabetes in youth. It is the largest one going on in the U.S. It's the only one like it of its kind. So it's important that we continue to be able to monitor these kids, because we're not only monitoring the epidemiology, but we're also collecting biologic samples and being able to better understand the forms, plural, forms of diabetes that occur in these kids. And certainly we need to understand much more about the forms of diabetes overall. As Sue said, we primarily call them type 1, type 2, gestational, and then there's actually a third category that's kind of the catch-all other category. But even within those, we have many more questions to understand. So this gives you a bit of a background. Overall, here's kind of the take-home message. In Search, in this population of kids, about 154,000 youth were diagnosed in that group, 15,000 diagnosed annually with type 1 and 3,600 with type 2. Let me show that to you in a little bit different format. And I think for some folks, this is, we certainly are concerned about type 2 diabetes in our youth. It's a form that we never used to see before. But let me draw your attention here. At 0 to 9 years of age, this is non-Hispanic white, African American, Hispanic, Asian Pacific Islander, and American Indian. And you can see type 1 diabetes is still the most predominant form of diabetes in youth, certainly 0 to 9 for sure. This is type 2. There's a little teeny blip there, but really very few cases of type 2 diabetes in 0 to 9. But let's take a look at 10 to 19-year-olds. Still, type 1 diabetes is the most predominant form of youth, except for American Indian children, for which type 2 diabetes is now the predominant form in that population in 10 to 19. And close on the heels are African American youth. And so as we continue to monitor this population and we continue to study this, we may certainly see these numbers increasing as we see the obesity in children increasing, that this again is a strong contributor to the growth in this particular disease in these children. But there was, and we get a lot of people thinking that, oh gosh, now type 2 diabetes is very predominant. It still is a relatively low form of a disease in children, but it is on the rise, and it certainly should be causing us to think about specific actions we can take with our youth to help prevent or postpone this problem. And as we talk about the National Diabetes Prevention Program, that again is targeted toward adults because that's where the evidence is. NIH is now doing some studies to look at what kinds of interventions will be effective in youth. Many of them certainly would take place in the school setting, and a lot of it does have to do with helping kids be more physically active as opposed to necessarily being in a special program. This gives you a sense of what it looks like by race ethnicity. And again, this is per 100,000, so again, a little bit different form of information. This is the annual incidence. So back up a minute. This is prevalence, total number. This is incidence, which is numbers on an annual basis. So this is 1 year's worth of data. This data is reported from 2002 to 2005, but this is what it looks like on an incidence, new cases of diabetes as opposed to total cases at the time. So still a somewhat similar breakdown, but you're certainly now seeing changes in this African American population as time goes along with more new cases coming forward. I wanted to be sure to give you some characteristics of these children as well, because it is important to be able to describe some of the characteristics. So we've been collecting information about how many of them are consuming less than 5 servings of fruits and vegetables, who has low physical activity levels, and you can again look at the difference between type 1 in this set of bars and this set of bars. So here's household income and parental education. This is giving us a sense, again, of some of those social determinants. What are the environments like in which these children are living? What kind of income do they have? And what kind of parental education do they have? These are all, again, contributors to health within the household. So it gives you a sense of what those look like. And here's the information on overweight and obese. This is, I think, an interesting piece of information. Most people think that children with type 1 diabetes are thin. Many of them are. But as our youth overall are gaining weight, look at our type 1 kids. They also are overweight or obese. And in fact, if you look at type 2, there's almost more overweight type 1s than type 2s. So you can no longer really just say that a child with diabetes who is overweight is absolutely going to have type 2 diabetes. And this really tells us that our youth overall are becoming overweight and obese, and they still can present with type 1 diabetes. It isn't only type 2 that our overweight youth have. So something else for us to be really focusing on and thinking about. And here's the information I mentioned earlier about fruits and vegetables. These are, again, some lifestyle habits being a measure of nutrition intake and a measure of activity level. And you can see between type 1 and type 2 children, a lot of them are getting less than 5 servings of fruits and vegetables a day. That's not an issue held only by children with type 2 diabetes. It's an issue for both forms of diabetes in our youth. And same with low levels of physical activity. A bit higher in those with type 2, but still an issue in our youth with type 1 as well. Wanted to give you a little bit of biochemical data on these kids. This is just a sense of some of the data that we collect out of this study. And this is, again, what's happening to the minority youth with poor glycemic control. And you can see here, broken down by race, ethnicity, 12.3% of the type 1s have poor control, 12.2% with type 2, and so on. That's non-Hispanic whites. This, again, gives you some racial and ethnic disparity data on what's going on with blood glucose control, glycemic control. In high-risk ethnic groups, you can see down here, 52% of youth with type 1 have poor glycemic control. That's over half of them, compared to 12.3% of the non-Hispanic white population. So again, we've got certainly some work to do in the disparities and how to improve outcomes and management in these youth. Okay, so that's pretty much been prevalence in adults, prevalence in kids, with some other stuff on kids thrown in to give you a sense of some of those social determinants, some of the other descriptors or contributors. And now let's take a look at the projections that CDC also does. How many of you have heard 1 in 3 born in 2000 will develop diabetes in their lifetime? Anybody ever heard that statistic before? Okay, that comes from our group. Sometimes people say we must have a crystal ball. How can we project this? It's again done with really sophisticated mathematical modeling. And let me just underscore the fact that we are not predicting that this has to be the future. This is if we stay on the course we're on. Because we obviously model these data based on the trajectory, the rate of increase. Those things are all used in the mathematical modeling to project these numbers forward. Our latest data says 1 in 3 to 1 in 5 will have diabetes by 2050. So that previous one I said, 1 in 3 born in 2000 will have diabetes in their lifetime. That's a lifetime risk. This newest statistic is 1 in 3 to 1 in 5 will have diabetes by 2050. So if we count 1, 2, 3, 1, 2, 3, 1, 2, 3, right now it's about 1 in 10. So if we stay on the course we're on, if we continue on the trajectory that we're on, as many as 1 in 3 people will have diabetes. So if we think we have a problem now, we ain't seen nothing yet. So this really tells us that we have got to think about what are we doing to help prevent or postpone new cases of diabetes. And right now we only know how to prevent or postpone type 2. Science will continue to forge forward, we hope, in preventing type 1 diabetes, but we only know how to prevent or postpone type 2. So we better be doing something, and that also means that we've got to be looking out for the care of those that develop diabetes, because there's no 100% way of preventing diabetes. So there will continue to be people who will develop diabetes. So it's not a question of do we deal with care or prevention. We have to do both. And because we have to do both, it means we have to choose wisely. It means the things that we are doing and investing in for managing diabetes, helping people manage diabetes, we need to choose those things that are evidence-based and are effective. And those things we're doing in prevention, we also need to follow that same criteria. We can't just sort of run helter-skelter at everything and we also need to not just be doing it a few hundred people or a few thousand people at a time. We've really got to be implementing things that are able to be scaled up and to reach a significant part of the population. And I'll touch on a couple of those in closing, and certainly more about that this afternoon. So here's what the predictions, the prevalence looks like in the future, and had to toss in some international data as well. All the data I've given you so far has either come from the CDC or, again, from the CDC, either through our fact sheet and our epidemiologic surveillance system or from the search study. These data come from the International Diabetes Federation, IDF. Some of my team members work with IDF on their diabetes atlas. This is their international atlas. And so this gives you a sense of what it looks like now in 2010 and into 2030. Here's the population of the world, billions, 7 billion, 8.4 billion in 2030. And here's what it looks like for diabetes, 6.6 billion now, 7.8 into the future. And this impaired glucose tolerance is one of the forms of prediabetes. We have a couple of ways we define prediabetes. We also refer to it as impaired glucose tolerance or impaired fasting glucose. So this gives you a sense of what those numbers look like internationally or worldwide. And then to look at it a bit more in detail by country, this gives you a sense. If you wonder who the big contributors are in the world, it's India, China, and the US. We're the biggies when it comes to prevalence today and prevalence tomorrow. And it really does remind us this is an international problem. There are issues we are working with our colleagues internationally on, and it really is a global issue, and one that again impacts developing and developed countries, and one that has real issues in many of these places with getting medication, particularly insulin, to people who have this disease. So lots of work to be done internationally as well. So I'll give you a bit of a...
Are these slides available?
We can make them available to you. I'll give my card and the folks here at APHA.
Okay, if you will post them on the NPF website.
Fabulous. Yeah, happy to do that. I work for all of you, so you're welcome to have our information. Let's turn our attention briefly. We've now really talked about prevalence and we've talked about incidence. We've given you some of those big numbers. Dr. Kirkman mentioned some of these issues around, gosh, the great stuff when you live with diabetes. This is really the great news you love to hear. Great, we're the 7th leading cause of death. We have number 1 cause of amputations, number 1 cause of kidney failure, number 1 cause of blindness. Now we have to worry about things like Alzheimer's and dementia. We are at higher risk for certain forms of cancer. So there are a lot of, yes, not such great things related to diabetes, but I would totally agree with Dr. Kirkman's comment. The good news is there are things that we can do about this. This does not have to be your course. For those of us that have had diabetes for more than 30 years, honestly, it's a miracle any of us are here and able to function and really speak. There are more and more people now who are celebrating 50 and 60 years with diabetes, but we were definitely, my generation, we were in that group that was told, well, if you live to 40, good for you. Fortunately, that's not how my family viewed it, and I think that has a lot to do with how well people are able to do, is that they've got access to tools. It's not only that they have access to those tools in medical care, but they do know how to use them, and they're given ongoing support. So while this is, again, kind of the bad news part of the story, there are things that can be done about it. And here's some more detailed data. Again, all of this is in our fact sheet that will give you the sense of 2 to 4 times more likely for a heart disease and stroke, which of course is the number 1 killer, first and third killer in this country. Diabetes makes a big contribution to that. And hypertension, eye problems, and kidney problems, all things that you had heard about. But here are the specific numbers to attach to those problems. Nervous system disease. And this group of complications here that are a dental disease, pregnancy complications, greater susceptibility to influenza and pneumococcal disease. This is why we really, really encourage people with diabetes to get their flu and pneumococcal vaccines. This is one of the things that ADA did not originally have in its standards of care, but public health's contribution to this encouraged them to put those vaccinations in their standards of care. And depression. We've got just a whole host of wonderful things we get to deal with. Depression is potentially both a contributor to the development of diabetes, but it absolutely, once you develop diabetes, is something that people are challenged by. And I guess I would just maybe paint the picture for you all this way. This is a 24/7 gig. You get no vacation, you get no break. And yes, you can try to do things that try to certainly lighten that dedication that you have to have, but this is a daily journey. And you wake up each day needing to face things that others don't have to face. And so is it the end of the world? Hopefully not, but you are always carrying on your shoulder blindness, amputation, premature heart disease and stroke, kidney failure. And those are burdens to bear. And so that's really what we describe in public health as our goal, is to reduce the burden of diabetes by making it easier for people to live with this disease, by helping them get access to the necessary tools and education, and to really look at having that ongoing support available to people. This is just going to flash up a couple pieces of information for you. I mentioned earlier that the death rate due to diabetes is declining. What does that do? Makes the prevalence go up. Remember, it's one of the contributions to the maps getting darker. But this is good news. We're not dying as prematurely from diabetes as we were. So this does tell us that we are doing some things more effectively. One of my team just published a paper today. It's just come out today. That does talk about, while we have a longer life with diabetes, what is the quality of that life? How much of it is spent with fewer complications? Are we just prolonging life, or are we prolonging quality of life along with prolonging duration of life? So that paper has just come out. And then here's information about what's been happening to vision impairment, and you can see that that's also declining. Same slide is true for renal failure as well. But also, as Dr. Kirkman pointed out, and this is something we do have to remind people, it is important to really note that because the prevalence of diabetes is increasing, the rate of these complications is declining, but total number of people with these complications is going up just because of the sheer increasing numbers of people that have this disease. And then I just put this one in because oftentimes we're asked about how people manage their diabetes. This gives you a sense of some of the other kinds of data that we collect. About 58% of people manage their diabetes with medication only. Here's insulin and orals, insulin only, and no medication. And let me use this opportunity to make a statement about people with diabetes who manage with no medication at all. Some people do seem to want to call that your diabetes has reverted or has been in remission. People can certainly choose to use those terms. Many of us would challenge that statement, however, because it implies that food and physical activity are not involved in the management of diabetes. Physical activity and nutrition are treatments for type 2 diabetes. It doesn't mean you have to only be on medication if you have diabetes. Food and nutrition and physical activity are treatments for type 2 diabetes. If people go off of those healthy nutrition plans and physical activity efforts, then their blood glucose level will go up. And certainly type 2 is a progressive disease, and so medications absolutely may need to be added over time. Type 1 diabetes, nutrition and physical activity are contributions to the treatment program, but we would not survive without insulin. But in type 2, nutrition and physical activity are treatments for type 2 diabetes. So whether or not that means that your treatment is less complex, or maybe it doesn't involve the added expense of medications, that's certainly a positive statement to make. But it is important for people to realize there is physical activity and nutrition treatments for type 2 diabetes. You've seen these cost data. These actually do come from the American Diabetes Association and the Lewin group that they work with. So you've seen these just to, again, remind you of those numbers. Costly disease, costly in terms of personal cost and in terms of financial cost. Okay, let me wrap up with just a last couple of comments on some strategies. And it's always challenging for me to talk only about the data and not talk about solutions, because one of the things we do at CDC is to manage the nation's surveillance system. But a huge part of the work that we do is developing interventions and testing interventions, public health interventions for helping manage diabetes and help prevent the disease. So this is, again, my top line. If I'm in the elevator with a member of Congress and they ask me, what is it you do in the division? These are our three strategies, or the three things that we're working on. We want to prevent diabetes, we want to prevent the diabetes complications and disability, and we want to eliminate diabetes-related disparities. Those are the three things that we focus on. That's what our research focuses on. That's what our public health programming focuses on. And in order to do that, I really want to come back to this notion of this kind of model and approach. I'm asked very, very frequently about personal responsibility and personal involvement in managing a disease or preventing a disease like diabetes. And I think this has become the best way for me to describe this to people, is to use this, what we refer to as the ecologic or socioecologic model. In the middle is the individual. So anyone who lives with diabetes or with pre-diabetes, you bet, we have a responsibility to make better choices, to make effective choices, to stay on top of the things that we have control over. But I would draw your attention to the statement at the bottom. The health of individuals is inseparable from the health of communities. So you can't do this all on your own. You can't do this flying in the face of a whole bunch of counter-healthy things flying at you. So if you look at what you can do as the individual, that's really important, and that needs to be exercised as much as possible. But if you move out here to the next rung, family and friends and the small group around you, the habits of your family, the environment of your family, the area that you live in, those things all influence how well you're able to manage your disease. And it's also really, can think about this as a family disease. For those of you that have family members with diabetes, you're impacted as well. You may not be walking in that individual circle, but you are impacted, and you can have an impact on people who have diabetes. So it's an important perspective, both from one of support and for one of influence, that we not lose sight of. Then you move out to this ring, which is system, group, and culture. And this is things like, where do you go to school? Where do you work? Where do you worship? Where do you get your health care? All of those kinds of systems are also very important for influencing how well you're able to manage diabetes, how well you're able to prevent it. Are there policies in place within your work site or within the school setting? You heard some of the discrimination issues. We could talk about a lot of those because that is a major area that the ADA fights on behalf of people with diabetes. There's some phenomenal suits that have come up that have to do with people being able to use their testing equipment in their workplace or in their school setting, people being able to take their blood glucose testing supplies to concerts. We've had to go to court over that. So there are a number of areas where people with diabetes have either been unable to access the supplies and food that they need to take care of themselves, or they have been unable to hold a job for which they are otherwise qualified. So these kinds of things out in that rung, they impact how well you'll take care of your diabetes, how much you'll talk about it, how much you will self-reveal to people, because it all has an impact on how well you're able to cope and adjust with your disease and to be able to manage it well. And finally, we get out here to community and policy. And this is really where policies do have a big impact. What are the healthcare policies in the country? What are the other kinds of things that are done not only to give you access to services, but what are the things that are done in the environment to make the built and physical environment in which you live? How easy is it for you to access foods? Is it healthy foods? Are they pretty readily accessible, or do you live in communities where there are very few supermarkets that stock fresh produce? Do you have to travel a long distance to get your supplies that are, again, whether they're medical supplies or they are food-related supplies? So I would just encourage everybody to think not just about what the individual with diabetes can do. Again, they're central. They're in the center of this. But all these other things influence the ability to do that successfully. And finally, I'll close with this thought as well, is that we really are working to approach diabetes in this clinical community. There was a lot of talk about this under the health reform discussions, and there is work going on right now in diabetes, both the management of it as well as the prevention of it, that really does give some outstanding examples of connecting the clinical system to the community. And the one I will give you is the National Diabetes Prevention Program. We are working now to help clinicians have that conversation with people about their risk. Clinicians can do a lot in that area to test people, to diagnose them with diabetes and pre-diabetes, and to refer them in the case of prevention, certainly to the National Diabetes Prevention Program, which moves them out into the community. So I think if any of you are familiar with the chronic care model, that's what a lot of these are here on the clinic side. You want informed, activated patients. You want a prepared, proactive practice team. Those are important things that happen within the healthcare system. How much time do you think people spend in the healthcare system? Hours? Hours per year? How much time do they spend out here in their communities? Days, weeks, months. And so it doesn't mean that this is not an important infrastructure for us to be attentive to, but if people get super great information and services and then they go out here where there's not very much support or it's a very difficult environment to live in, we're working at cross purposes. So if we can really figure out, look at all the things that we can do together. In the diabetes prevention program, a lot of the clinicians would say, I don't even have the conversation with my patients about prevention because I'm too busy taking care of the health issues, the diabetes that they have. But what an opportunity for us to really hone in on what they can speak to their patients about and then refer them to community programs that have proven to be effective. And I'll share more about the national program this afternoon. But it really is an opportunity for us to link the clinical system and the community so that we are maximizing each of those sectors. And quite frankly, we're playing to their strengths, not to their weaknesses or their limitations. So in closing, more people have diabetes and are developing it. There's a take-home message. Future projections underscore that prevention is critical. If we don't work on better preventing diabetes and preventing those complications, the burden of this disease will overtake us. Many liken this to a tsunami, and it really needs to be looked at in that way, whether you consider it to be the Titanic and the iceberg or a tsunami or some other, as some would say, a slow-moving tsunami. This doesn't happen overnight. There are things that we can do to get a better handle on it. Diabetes management remains a priority, as does eliminating disparities. A lot of the improvements that I mentioned are only going on in certain subsets of the population, and we can't allow that to happen. That really needs to be much more evenly distributed across the population. And there are effective diabetes prevention and management interventions. We'll talk a bit more about those this afternoon. The deal with those is that they need to be scaled and they need to be sustained. It's not that we don't have some excellent interventions and some excellent tools. No, we don't have cures yet, but we do have some excellent tools, and what we need to do is get them in more people's hands and have more people be able to benefit from them. Thanks.
So we have about 8 or 9 minutes for questions, so please step to the mic if you've got a question for Dr. Albright.
And anything you want to bring up, we'll give it a shot.
I wonder if you could talk a little bit about, you said the big three are India, China, and the United States. My impression, not having traveled to either of those countries, is that obesity is much less a factor in those cultures than in ours. So if that's true, doesn't that weaken the obesity causation argument for us?
That's an excellent comment. Ironically, I just got done and my team answering this question for Dr. Frieden, our agency director, over the weekend. There actually, as it turns out, there is a greater likelihood of people of Asian, South Asian descent developing diabetes at a lower body weight. And in fact, when we've set the entry criteria to the national prevention program, we say people with a BMI of 24 or greater, if you're Asian, 22 or greater. So based on their pathophysiology, and a lot of it is looking at the fat cells themselves, the question earlier about liver, a fatty liver, that's also being examined in those populations. So it very much has to do with the pathophysiology and the fat cells in those populations, but they do develop diabetes at a lower body weight.
I'm going to ask you, Dr. Albright, to put on your exercise physiology cap right now.
Sure.
Considering that you said exercise is a treatment for type 2 diabetes, is there, what are you finding, what are you seeing, what does research say is effective exercise type when it comes to not curing but treating type 2 diabetes? Are we looking at that, 45 minutes a day of moderate exercise or 30 minutes a day of intense? Are we seeing that better result comes from so-called strength training, weightlifting type exercises, or some combination thereof?
Yeah, it's a great question. We just finished in December 2010, which you may want to take a look at, is the position paper. It's a joint paper by American College of Sports Medicine and the American Diabetes Association. And there's an entire paper where we examined the literature very thoroughly to talk about those multiple forms of activity. You're challenged sometimes by the quality and number of studies that have been done in the diabetes population specifically. So let me try to do my best to give you a succinct answer. You really do need to be participating in aerobic activity, so that's a given. That's a must. Weight loss is also a goal for the program, which it isn't for everybody, but certainly for many, many with type 2 it is. You can be looking at either a bit lower intensity, so more moderate physical activity, and a duration that's more like 45 to 60 minutes. You can do more intensive physical activity with a lower amount of minutes, so that 20 to 30 minutes is likely in that regard. Those tend to trade off. Now, many people who have a lower fitness level, they're going to be much more inclined to be able to do more moderate intensity and do it for a longer period of time. But that doesn't mean if you're not inclined to be doing something more rigorous for a shorter period of time, that is an option. But that's where the individualizing comes in again. You have to determine, is this a pretty unfit person? And so you're not going to obviously tell them to get out there and do 30 minutes right out of the get-go anyway. You need to start people and advance them slowly. So ultimately, you'd like to get people to that 30 to 45 minutes of moderate activity, 45 to 60 minutes for weight loss. If weight loss isn't a goal, then you can pretty much hang in that. General recommendation for everybody, 30 minutes, moderate physical activity is going to be effective. Weight training or resistance training has been shown to be effective in those with diabetes. Again, you have to exercise some safety cautions. If people have retinopathy, they have proliferative or active retinopathy. I did my dissertation work in exercise and diabetic kidney disease, diabetic nephropathy. You've got to be careful about elevating the blood pressure too high, no Valsalva maneuvering while you're lifting and that kind of stuff, because that'll drive your blood pressure up. But it turns out that doing weight training increases your muscle mass. Again, that's weight training or resistance training, and resistance training is probably a better way to say it. That's the TheraBands, that's the weights, that's the whole kit and caboodle. That is effective because it makes your muscles better able to utilize glucose more effectively. So the winning combination is 2 to 3 days a week of resistance training and 5 or more days a week of moderate intensity to high intensity aerobic training.
I was wondering about your statistics on mortality, on complications. If someone has heart problems, will be registered as heart problems or eye problems, but not related to diabetes. So how do diabetes comes into the statistics when it comes to say, okay, diabetes is directly responsible for this or for that, or do we overlook diabetes and the side effects?
Yeah, let me make sure and help make sure I answer your question. When we collect these data, we first get the pool of people with diabetes. And the way these surveys are run is that mathematically you determine what sample out of the, for example, the NHANES or the NIH survey. We get a sample of people who have responded yes to the question about ever been told by a clinician or physician that you have diabetes. Once we have that pool identified, then we begin to look at eye problems, foot problems, kidney problems. So we don't just generally look at the whole population overall for eye and kidney disease. We're looking at it specifically within the diabetes population. And so because we know that those diseases are contributed to by high glucose levels and high diabetes, if somebody reports having diabetes, then it would be highly unlikely that their kidney disease or their nerve disease would be non-diabetes related because it's such a significant contributor. Dr. Kirkman mentioned earlier the issue of the mortality and how likely that is to be underrepresented, because it's true that on death certificates many people are not reporting diabetes as a contributing or underlying cause of death. So that is an underreporting.
Okay, last question.
One more. Thank you. You've given us a very complete picture of the various contributors to the diabetes epidemic. But I'm curious, when you look at the rising burden of diabetes, how much of it would you say is due to people living longer with the disease and people being diagnosed earlier as opposed to more people actually getting diabetes?
Yeah, John, that's a great question. In our analyses, it is not possible for us to determine what percentage each of those contributes because our data does not allow us to do that. However, when you look at incidence, it's certainly a major contributor is new cases, yes. And that's really the only way we can sort of pull out incidence from that. But because people are living longer, it has been something we've tried to communicate more effectively to people, because when they do look at the prevalence maps, it's almost as if no one has really been willing or had been thinking about the fact that, yes, if people live longer, prevalence is going to go up. As more people are diagnosed, yes, the prevalence will go up. So it's important for us to point those out, but we would suggest that the major contribution still is new cases of diabetes. Thank you
so much. We have a certificate of appreciation for you from the National Trust Foundation. We really appreciate it. Thank you.